Nu så ska vi spetsa våra engelska öron och tack och lov är det inte jag som ska leda det här samtalet utan det är Bjerre Ljungberg som sitter med i styrelsen för Vän i Umeå och han är också en av dem som har varit initiativtagare och planerat den här konferensen. Det blir säkert så att ni har några frågor och funderingar. Skriv dem då i chatten och i mån av tid ska vi försöka bolla in det till våra vänner i England i slutet av deras presentation. Over to you, Bjerre.
Thank you so much. Ladies and gentlemen, I'm Bjerre and I have had the pleasure of connecting with our first two lecturers, Jenny Hartnell and Bogdan Chiva-Dziurga from England. So short introduction, here we see Bogdan, Jenny's, they're wonderful. A short introduction. Jenny is the person who started more or less the From Mendip success story together with Dr. Helen Kingstone. And she has shaped the structure and the mentality behind the From Mendip spirit and Let's Connect. And she has designed the web directory, the health connectors, community connectors, and now lately also Pay It Forward, and you name it. Amazing. And we have Bogdan Chiva-Dziurga, a development lead for the Global Social Prescribing Alliance. Ni vet, social aktivitet på recept. And a clinical champion for the National Academy of Social Prescribing. And he is dedicating his career and his life to preventive healthcare. Impressive. So if you have any questions, please write them in the chat and there will be 15 minutes answering question discussion time towards the end. So please, Jenny, what can you tell us?
Thank you. I'll just share my screen. Here we go. Can you all see my screen? Yep, great. So I'm just going to tell you the story of the work we do in Frome, which is a town in Somerset. And I'm going to tell you how GPs, so doctors' practices, work together with communities. And we've created a service called Health Connections Mendip, which is a social prescribing, community development and health coaching service based in Frome, but we cover 10 doctors' practices with a population of 118,000, but it started with just two people, me and Dr. Kingston, with an idea. So I'll talk you through a bit of a story to start off with. Just trying to get to my next screen. Okay, so here's Mary, and Mary goes to see a doctor. And, oh, my screen's... Mary is feeling anxious. She doesn't quite know why. She's put on a lot of weight, and she really doesn't know what to do about it. And she has financial problems, and she has no idea where to go and what to do. So the doctor hears that Mary has a complex life, and she's unsure what to do. So in Frome and in the towns across our district, our region in Mendip, what the doctors would do is they would listen carefully to Mary, and then they would help Mary contact a health connector. And a health connector is a social prescriber and a health coach in our area. And the health connector is a paid member of the doctor's practice team. She's not a counsellor, she's not a therapist, and she's not medically trained. But what she'll do with Mary is visit her in the GP practice, at home, or speak to her on the phone. And she'll find out from Mary what matters to her. So she'll have about a 1 hour conversation in that first conversation to find out what's important to Mary. She will help Mary set goals and make changes that are meaningful to her. She might work with her about her network around her, who her friends and her family and her neighbours are, and how she can build up that network, if that's what's important to Mary. And our team will write on the medical staff's notes the information about Mary. So it gives that equal importance to the medical information to the non-medical things that are happening in Mary's life. So when a doctor sees Mary, they can read the notes that the Health Connector has put there as well. Now, what the Health Connector might do with Mary is she might signpost to support and information on our website directory. So just to say that in Umeå, I imagine you have these kind of workers. You might have them based in doctor's surgeries, you might have them based out in the community, they might be based in the council. So this is just really explaining about that one-to-one worker. And as I said, they might signpost to things on the directory. Now, on our website directory, the Health Connector might look with Mary at things like healthy eating. That might be what's important to her. It might be about linking to support groups. It might be about being out in nature. It might be about pain management. It might be about how to improve sleep. It might be about becoming a volunteer and joining other people in the community. It might be about reducing her anxiety by being with animals and pets in nature. It might be about how to be in nature and connect with others to reduce her anxiety and maybe lose weight. It might be about doing cheap or low-cost sports activities. Or it might be information leaflets and booklets and websites that Mary might want. But once we've listened to Mary, the Health Connector can look at all these things with her, and then it's for Mary to decide what she wants to do. And this information is all on our website directory. So I imagine in Umeå, you might have a website directory. So that's a question, really. Let's look at another story. Oops. This is a different lady. This is Kathy. Kathy is also feeling anxious, but she knows exactly what she wants to do. She wants to go and walk out in nature with friends, but doesn't know where the walking groups are. Kathy also has put on lots of weight, but she knows that she's heard of a 12-week weight loss course, but she wants to know where it is. She has problems with finances, but she knows that there's somewhere in the community, but she doesn't know what time it's open where she can get that information. So Kathy goes to the doctor, and the doctor hears that Kathy has a complex life, but she knows what she wants. So the question there is, does the doctor tell her to go to a Health Connector? No, the doctor doesn't do that. What the doctor does is simple signposting. So the doctor will print out information on the website directory about that 12-week weight loss class, about the walking in nature group, and about the service to support her with finances. So the doctor does that straight away. He gives her that information. Or he can say to that lady, Kathy, why don't you go on the website directory and look for that information yourself? Well, maybe he hears that Kathy doesn't like going on the internet. So he suggests that Kathy calls up one of the Health Connections teams, and Kathy can call to the Health Connections and say, I want to know about that weight loss group. I want to know about the walking in nature. I want to know about the finances. And on the telephone, one of our team members can give her that information. It might be that Kathy doesn't like going on the internet, doesn't like making phone calls. Maybe she wants to go to a physical place to speak to someone. So we have our talking cafes, which are places in towns across our district, which are the same time, same day, every week, where you can go and find out that information about supporting the community. So maybe Kathy would like to go there. During COVID, the places indoors were closed down. So we had a talking bench, which was a place where Kathy could go to find out information about the weight loss group, about the finance, and about the walking in nature. So these are all different ways that people can find out information. So I wonder, in Umeå, do you have a website? Do you have a phone line? Do you have physical places where people can go and get information? So let's have another story. Here is, I think, can you see in the middle? That's Sally. Now, Sally is also feeling anxious. She also has problems with finance, and she's also wants to lose weight. But she hasn't gone to a doctor. She hasn't seen a Health Connector. But what she's doing is she's sitting on a bench next to this person. Now, this person is a community connector. And this person is going to tell Sally how to get to those access points. So this person is going to listen to Sally as a stranger and say to Sally, there is support out there. So what are community connectors? Community connectors are members of the community who signpost friends, family, colleagues, and neighbours and strangers to support in their own community. To become a community connector is 1 hour training. Anyone and everyone can be a connector. It's not about being a volunteer. It's about being a citizen who has information about where to find support. And it's about people saying, I know what's out there. I know there is support there, rather than if only I'd known that. So we have trained up policemen, taxi drivers, hairdressers, students, doctors, cafe staff, supermarket staff, parents, grandparents, homeless people, housebound people, job centre staff. So this man here, who is sitting next to Sally, is going to tell Sally about the website, about the phone line, about the talking cafe, and about the talking bench. So then Sally can find out that information for herself. So this is just a bit of a story about what we've done in Frome. We haven't just relied on the one paid worker who works for the doctor's practice. We want everyone to have that information. We want to democratize information so everyone can have access to it in a way that suits them best. And here's just a little bit of a story about how somebody can go through that journey. This is a different person. Oh, sorry. In Frome, we've trained up 1,800 community connectors. And on average, we found out they have 20 conversations a year. So that's 36,000 signposting conversations happening out in the community every year. And the number of connectors we're training is growing and growing. So just imagine all that support that's happening out there in the community. And you could have this in Umeå. It's a very simple, very, very simple thing to implement. So, as I said, here's a bit of a story, a different story. A patient goes to see a doctor. Then the patient is visited by a health connector. Then maybe that person goes to a support group. Then maybe they go to a self-management group to talk about how to manage pain, and the person gets involved in supporting others in that group. Then maybe that person goes to an exercise group in the doctor's practice. Maybe they then go to an exercise group in the community. And then what happens is they train as a community connector. And the joy of this way of working is that people can come in at any place. Somebody might start training to be a community connector and then go and see a health connector. They might join a group and then become a community connector. They can do whatever they want. And this is just another story of the power of this way of working. As I said, during COVID, we couldn't have our talking cafes inside. So we quickly changed and we decided, where are people meeting? Well, they're walking through towns. So on benches across the region, we have one of our team, a health connector, who is on the bench with this flag, and she's there and she can tell people about support in the community, or she can just be there to talk to people the same time, the same place every week. And this has become so incredibly successful that she's become like an anchor in the community in this place. And we are there all the time. If it's sunny, rainy, it doesn't matter. We are always there. So this just goes to show how this way of working can be very flexible and can adapt. Another example of something we did during COVID was across the world, there's this movement called Pay It Forwards, where you can buy a coffee for yourself and you buy a coffee for a stranger. So we saw during COVID that actually the places people were going to were the shops. So our team went around all the shops in Frome and we asked them all to do Pay It Forwards. And so we had art shops, book shops, cafes, and all these places were doing Pay It Forwards. And you might say, why is a service that is employed by doctors doing pay it forwards? Well, the reason for that was because we were thinking, where are people meeting? Where are people connecting? And let's have a bit of kindness, a bit of connection in those places. Another story, this is coming to the end of my stories, was that I saw this amazing booklet, which was in Scotland. And I contacted the organisation in Scotland and I said, can we copy this book? And this book has lots and lots of information about supporting yourself, supporting your mental well-being, connecting to others. And she said, of course you can copy it. So in the back, it had all the information about the support in the community. So we changed that from the Scottish information to the information about our area. It was 1 week that I saw this booklet. We adapted it to our area, and then we printed out the books, and we needed to get it to every household in our region. So we called out on Facebook, on Instagram, and we said, we need volunteers to come and collect a box of these booklets and to deliver them to people in your street. And we had queues of people, and these volunteers, well, not volunteers, these people delivered this book to 47,000 households in our region for free. And that took 1 week for the turnaround. So in 1 week, everybody in our community during lockdown, when nobody could go out, had this information about how to cope with things and about where to get support. But we could only do this because we were able to contact those people in the community, and we had this feeling of people in the community that they want to link in with each other, they want to connect. So basically, all over England now, doctors' practices are able to have roles like the health connectors. So there's funding nationally for us to have these roles. Some services, like ours in England, have a website directory. Some services have a phone line. Some have physical places where people can go to get information. So this is a general kind of model, this first bit. But I think the real magic of what we've got in Frome and in Mendip are these community connectors. So as I said, we've got thousands of these community connectors. And during COVID, we realized that we could expand this model because there were people who couldn't get online and needed support, digital support. So we've now got over 100 digital connectors. We also do green social prescribing, and we've got over 100 green community connectors. Once again, really simple 1 hour training about how to reduce your carbon footprint and get involved in nature. We have hearing support connectors. We have healthy lifestyles connectors. We have planning ahead connectors for people who want to talk about what happens when they become less well, or if they are towards the end of their life, things that they can put in place. Once again, really simple 1 hour training for the people in the community to be able to have these kind of conversations. We also have warm home connectors. There are lots of people who live in cold homes, and actually really simple 1 hour training can help improve that. And as an example, we have that pay it forwards, and this is one of our projects. So all the connector work is our training, and I could do a whole nother conference on all the projects we do, but I'll just give the pay it forwards as an example. But basically it shows that social prescribing link workers and health connectors, those one-to-one workers in the middle of it, alongside the training and the projects, can be really simple. Anyone can do it. It's not complicated. It involves the whole population. Having a talking bench, having pay it forwards, having connectors involves everybody. They can be easily replicable. We have shared this in England, in Australia, in Canada, in Germany, in Switzerland. Lots of people take little bits of this that they like and they copy it. Anyone and everyone can be involved. If somebody, for example, wanted to train as a community connector, they could just train as a connector. They don't have to talk to anyone, ever, but they know where that information is. They're really common sense. They're not complicated ideas. They're easy ideas, and they belong to everyone. And it really helps create a feeling of a movement in a town, in a region, that something exciting is happening and that we're all doing something together. And that's why this work we've called Let's Connect, because Let's Connect is not about an organization. It's something that everyone can get involved in. And they don't cost much. These ideas are really cheap and simple. So it shows that social prescribing type services based on what matters to individuals, but also communities, can be exciting, innovative, place-based, and belong to everyone. But people often say, oh, well, it's just Froome, Froome's got a certain magic, and that's not true. These things are happening everywhere. They're happening in Umeå. Things I'm saying now, you're probably thinking, yes, we have that. And people often say, where do we start? And so I think you start with those sparks. You start with those people who have the passion, who have the energy. When I first met Beer, I could see that he was one of those people who had that energy. And look what's happened now. You've got this conference. And then it's about linking those people with that energy, linking them all up. All the people on this conference, you've got that energy. You will make things happen. And it's about trusting that things will happen. My line manager, Dr. Kingston, completely trusted me. She said, Jenny, you are the expert in this work. Go and do it. It's about trusting people. And without that hierarchy of her being a doctor and telling me what to do, she said, go and do it, Jenny. And then it's about seeing the ripple effects of doing one thing and another thing and just trusting that that will happen. And then just seeing the magic that happens. And that's it from me. Thank you.
So thank you so much, Jenny. And we're glad to hear that it's simple, it's cheap, it's replicable. And we now ask the audience for questions, but we ask Bogdan to give his presentation first, and then we allow time for questions. So once again, thank you very, very much, Jenny. And we welcome Bogdan. I should say in Swedish. You could write in the chat. Ni kan skriva i chatten frågor, så kommer Anna och sortera lite grann, och så tar vi ut de frågor vi hinner med på 15 minuter efteråt. So please.
Thank you very much, dear, and thank you. Fantastic. I'm trying to share my screen, but I think the host needs to allow me to share my screen if possible. That'll be fantastic. And in the meantime, just wanted to say, hey alla, nice to see you all and pleasure to meet you all. I think it was a highly passionate and fantastic presentation from Jenny. It was wonderful to see the whole ecosystem at work. And I think what's been built in there, and I think what the opportunity is here, is to build that wider ecosystem of involving people from the community and starting it from the ground with a real grassroots approach. So thank you so much for that, Jenny. It's beautiful to see that work in action. If anyone's on Twitter, if anyone wants to get in touch, I've put the contact details in there. But it's a joy to be here with you, and thank you to Pierre for the invitation as well. I'm Bogdan, and I'm part of the National Academy for Social Prescribing. If there's anything at any point you don't understand, please let me know, and I'll try and clarify in the question section. I will also try my best to leave time for questions, because it's very valuable to hear what really matters to you in terms of what you'd like to find out. And in this presentation, I really focused more on a clinical perspective, and I will give you a better background of how this looks in the UK, but also move into the global sphere and talk a bit about the Global Alliance of Social Prescribing, which were developed. And we would love to invite you to become part of that with the work that you're doing in UMEA. So a bit of background about the National Academy for Social Prescribing. It's a national body that's been set up through the government to support the delivery of social prescribing. So the services that Jenny mentioned earlier as well. And essentially there's various programs, but at the core of what we do is trying to support patients live their best possible life. So it's about patients trying to do their best to have an increased quality of life. And so there's various programs including lots of noise-making opportunities, such as an ambassador program. There's the Global Alliance I'll speak about later. There's clinical champions. So how do we get clinicians on board with such movements? Then there's the Thriving Communities Fund, which was set up to look for gaps within communities and empower and support local voluntary care sector communities through funding that was commissioned. There's the Academic Partners Collaborative as part of the National Academy, which looks at the evidence behind all of this. And I know much of the time we want to talk about the evidence and the proof that things are working, although we know inherently that these things are working very well. And then there's something that we call a social prescribing innovation accelerator, which looks at great ideas that have been implemented throughout the UK, but also later across the globe, where we hope to highlight some of the work that people have been doing. I will only focus on these two here, so the Global Alliance and the Clinical Champions. But first, let me just take a bit of a step back. And I hope this is correct as I've translated it. I think I'm afraid that Google Translate doing a bit of work for me. But essentially, there are some things that we know as clinicians. And what we know so far is that in the UK, at least, 1 in 2 consultations are around mental health approximately. Actually, 60% of the consultations in general practice are around mental health. We know that social determinants of health impact on our health in quantity of 80%. And we also know that 1 in 4 consultations in the general practice setting will be around social reasons, pure social reasons. And around loneliness, we also know that we quantify the risks and we associate it as smoking 15 cigarettes every day. Yet, funnily enough, we don't see billboards with loneliness as we see billboards with smoking, right? Even though it's as damaging for people as smoking is. And so the interesting thing for me, being trained through medical school and being nurtured in such a way that I see the biomedical and the science aspects without being able to look at prevention so much, there's something that really scares me. And some said that I've dedicated my life's work to prevention. To me, this following statistic is what scares me as a clinician, because by 2050, we know there's going to be a double in size in the amount of people living in the world. We know there's going to be people aged 60 and above who are going to double in size, and we know that's going to double again by 2100 as well. So why is that scary? Well, that's scary because we know that the narrative and the culture that we've been living in with the healthcare systems that are set up for the acute and the firefighting that I keep doing in the hospital, we know that won't be enough. We also know that as clinicians in the hospital, although we want to firefight and focus on the acute emergent problems, there will come a point where the balance will tip the other way around. We know that chronic and long-standing diseases will have to be managed. And so this narrative around the sick care model starts being built even from the benches of the medical school curriculum. In fact, it starts being built even earlier from school, when we do work experience, when we go to see surgeons at work, and we always get taught about the intricacies of the human body, about the thousands of arteries and veins and bones and muscles. But we don't get told too much about loneliness and about social connection and the importance of mental health and so forth as well. And so we've really nurtured this idea of this sick care model, the idea of a fix shop mentality, of a repair shop, if you like it, a revolving door system, whereby we go to the hospital to seek health when we're ill. Whereas what that means and what that does, it means that we align ourselves as these medical experts in formal institutions and hospitals, white-coated doctors with pens lined up in here and telling patients what to do, when instead we should do what Jenny just said earlier, listen to what truly matters to them. But not only that, also meet them halfway and work together with them to empower not only the 1/3 of the population who is sick, but the 2/3 of the healthy people that are there as well. And so the sick care model used to be fit for practice at the time when it was set up, but we need to look at the changing culture. We need to start shifting the values and beliefs, not just alongside the community spectrum, but amongst the clinicians of the future, amongst the future generation of doctors, of healthcare professionals. We need to start looking at how we implement this into policy and to change the narrative and to change the conversation. And this is what Jenny was alluding to earlier as well. What happened in Frome is pretty much people getting together, meeting the doctors, the clinicians halfway, and being able to resolve some of their problems. And they were involved in shared decision making, and therefore it just led to patient activation. Now, you may say this all sounds great, and I've been in A&E in the emergency department, and I've worked through COVID, and I've seen it all. So you may say, well, but Bogdan, this is all brilliant, but how can you do this with only 10 minutes per consultation, right? There's some perceived barriers to personalized care and finding out what truly matters to the person. And sometimes the biggest perceived barrier, as you probably well think, is time. But there are some statistics that show that 59% of the family doctors, so the general practitioners, found social prescribing, found that they thought is reducing their workload rather than adding more workload. So that's a very interesting statistic to look at. And so from my perspective, where I come in and why I've started looking at this work and why I've got a lot of joy and energy behind it, and where the spark is, like Jenny mentioned for me, it's really to say that education, from my perspective, is the biggest barrier, not time. Time you can save and invest in education, and then you'll get that time back. Because if I then connect those patients with their link worker, with the social prescribing activities, it will lead to a reduction in appointments, and it will lead to a decrease in resources, and it will better the environment, it will better the communities, and it will lead to health creation, not just sick care that we tend to do in the acute scenario. And so this is where the idea of the Student Champion Program came around. And I will very briefly tell you, but we essentially developed an army of the future generation. And I launched this when I was a medical student myself around 6 years ago. And we created a program where we selected students from every single medical school in the UK, and we got them to teach their peers around bio, psycho, social, not just the biomedical approach, and to talk about social prescribing. And the scheme went very well. We partnered up with internships and hosted students from Harvard and from other places as well. And we managed to build this army of youngsters who are pushing for the culture change as well. The students got involved over the pandemic in some wonderful activities, like your own UME activities that I saw earlier. And I don't know much Swedish, but it was wonderful to see the wide range of activities you've developed together. And it's interesting to see the culture shift in the students' mindset then when you catch them early, when their mind can change. They stop talking about synapses and neurons, and they start talking about human connection and about how dementia impacts people, not patients. And so there's been some great success with the Student Champion Program. We involved all medical schools, and over the past 5 to 6 years, we've really engaged with over 20,000 students across the UK and completely changed the curriculum. So social prescribing is now part of every single UK medical school that we have at the moment. And that's a big, big statement. The students work together as part of the healthcare system to implement this and support the policy development as well. And then moving from here, we move one step forward. So now we're building the clinical champion program. So we're looking at buying in this enthusiasm from the clinicians as well, and not just clinicians, but wider multidisciplinary teams. So we're looking at discharge coordinators in the hospital. How can we involve them a bit more in the process? How can we get them to advocate for this better? And so in a similar fashion, we choose a few champions in different regions. We get them to learn about it. We get them to share their learning, and then we get them to reflect on their support. And very briefly to mention what we've been doing on the global alliance, to which you're all invited, and it would be amazing to have, and I know we have Sweden at the table as well, and it would be amazing to involve you a bit there in the future too. But the Global Alliance for Social Prescribing is a partnership with the United Nations, the World Health Organization, and the National Academy for Social Prescribing. And what we've been doing is we've been working with people from all over the world who are looking at getting social prescribing into policy, but also looking at systems at a local level, such as Jenny's example, where we can share innovative approaches across the world. And we've got Japan to Singapore to Sweden to Canada trying to do that at the moment. And there's various components, as you can imagine. I won't bore you with the details, but this is what we're looking at in terms of the strategy. We're building a bit of a membership where you can access resources and support to implement this within your local system, but also in the national picture and how social prescribing could look like. So we have one stream, one cogwheel is looking at the community work that international partners are doing across Sweden, Canada, Japan. And then we have a research and academia stream that brings in the evidence summaries and collates the evidence across the world. We have the workforce development, which is the students. We have the clinical implementation, which is the clinical ambassadors work and those who advocate for it within hospitals. And then we have the policy, which for me is a lot of noise sometimes, and we need to anchor it in the beautiful work that Jenny and you and all the people around the world have been doing on such activities around as well. I will leave you with this as well to read and to take away. There's a brilliant document that we put together with partners across the world, which it's a playbook. It's a guide to setting up good social prescribing and what good social prescribing looks like. It's aimed at local community leaders. It's aimed at people of all sorts who are trying to implement social prescribing within their own country. And we would love to see some eager students and the future workforce involved from your side as well. And there's a document for the students, and there's also a document for the senior leaders looking at policy. And there's a checklist with some aspects that you can look at in there, and hopefully you can download and access the link there. In the meantime, we are setting up the membership, which should be free of use for everyone. So you should be able to sign up to the newsletter and to the wonderful resources that we'll put together as well. Just an invitation to invite you to celebrate Social Prescribing Day this year. This was the day that we did in 2021 and reached thousands and thousands of tweets and millions of people. And this year, what we're looking at is a whole week for social prescribing, and we'd love to see a few of you involved. So 10th of March is Social Prescribing Day in 2022, and we'd love to get involved to make some noise across the world with this, because we need to feed into that culture shift and culture change together. Do get in touch. We'd love to hear from you, and I'll leave it to questions now, because I'm sure you have some amazing questions to share at the moment. But once again, a pleasure to see you, and do get in touch if there's anything we can help with.
And we have a question here to begin with. So we ask Nils Seje Larsen. Maybe you can ask the question yourself.
Thank you. I figured it might be a little bit easier. First of all, I want to thank a lot both you, Bogdan, and Jenny for great and very interesting lectures. I'm one of the responsibles in the commune for the public health issue. So this is very interesting. I had two questions, and the first one was in the presentation of Jenny, and I think you were a little bit into that in your presentation. That you had 3 cases, and those 3 cases, it started off with them going to see the doctor, and I was just curiously wondering, why did they begin with going to the doctor? But maybe that is this thing with, we don't feel so well, so we visit a doctor, even though maybe it could be something else. So that was the first question. And then also I am interested in knowing if, because it's a great work that you've been doing in Frome, and have you been able to somehow evaluate and get some data and see the effects of it on on health or well-being of citizens. And lastly, I think it's a very, very great way to build trust to a community, a system, and communication. So I'm really impressed. Thanks.
Thank you. Shall I just do the first one, which was, it's just the way I did my presentation, that it starts with the doctor. And I suppose because I'm trying to explain our service, which is we are employed by the doctors. And I think it was trying to show that there's one person who comes with lots of needs, another person with fewer needs, but also then showing the example of the person being on the bench in the community of saying, actually, you don't need to go to the doctor. But I was showing the more traditional social prescribing type services in the first one, but then saying actually how we've expanded it is that actually it can be out there happening in the community. And your second question, I can't remember your second question now.
It was about if you have managed to, with time, get some available data or results and people's physical.
So there's been a lot of work. So we do something called the Warwick and Edinburgh Wellbeing Scale. We do the patient activation measure, and there's been we've got lots of statistics on how that's increased people's well-being and increased their activation. So we've got all those statistics, but also there was a study on the reduction of hospital admissions along the work that around all the work we do, not just our service, but that whole movement in Frome. And there was a huge reduction in hospital admissions because the way the community that was all working together. And also we've seen a reduction in GP appointments, but reported by the patients themselves. We're a very, very small service, and we don't have a huge amount of resource, but we do have all the measurements that prove that it works. And I think in the National Academy for Social Prescribing, they're collating all that information and all that data on how this works.
Yeah, thank you, Jenny. There's something very useful that I think you should keep a heads up for everyone or anyone who's interested in the evidence piece. There will be a big evidence summary on various segments of this, including economic impact of social prescribing, impact on green spaces and how green spaces support people. So do have a look at the National Academy for Social Prescribing, and there's a tab under evidence, and there's something called Academic Partners Collaborative. And then you can sign up there. They are going to publish this in October. So there's going to be these summaries of all the studies with all the evidence in one place. And the next step is to now collate the evidence on top of this from each country around the world and to add into that evidence summary. And hopefully that feeds a bit into that as well. So anyone looking for evidence, that's a very good place to start for the evidence summaries. And just to add to your point, Niels, because I thought it was very interesting, the presentation to the doctor, and I know Jenny mentioned that, that's how it happened in the slide. But actually, Jenny, I would say often as a clinician, people come to you, like you said, Niels, they're not sure what's wrong. And they just need, they come to the hospital or to the GP because that's the system we've been building across the years. It's the sick care model, and the doctor knows it all, which isn't true at all and needs to change. And the UK is a lot to blame for that. US is even worse. And I know in Sweden it's much better than in other places, but it's the white coat, that we need to get rid of completely, I think, and work in partnership with patients.
So we also have a question about the so-called Frome spirit, the cooperation in Frome. How have you managed to get different parts of your society working together, healthcare, municipalities, civil society? Can you say a few words on that, Jenny?
It's all been about building relationships and very, very simple things like I invited people to work in our office here, and we have health and social care. So social care, I asked all the doctors one day in the medical practice, can you explain to me what social care does? And nobody really quite knew. Everyone had different examples. So I invited in the head of social care into our practice to do a talk to the GP practice. And so suddenly everyone understood what social care did. And I said to her, can we have one of your team members working in the GP practice, in the doctor's practice 1 day a week? And they said, yes, okay, which created these amazing relationships. And that's reduced the need for social care in this area by a huge amount. And that's relationships and understanding each other. The same with the town council. They paid £10,000 for our first 3 years of community connectors. And that was them understanding the benefit of that. So for us, it's just been a slow and steady bringing together, as I say, of those lights, of those sparks together and creating those relationships.
And regarding finances, you have the town council contributing, but also National Health Service.
Yeah, so the National Health Service pays for the social prescribing link workers and health coaches, but also the town council paid for our community connector program, and the district council gave us some of their staff time for the community connector program as well. So it's everyone putting in a little bit, but the core part of it is based around the NHS funding, which is very new. It's only been, how many years now, Bogdan? 2 years?
2 years, yes.
That every doctor's practice in the country can have these people who can look at someone's social sort of needs.
And the finance element is very interesting across the world as well, because in some places is the social worker that's being trained extra and receives extra support and extra training. For example, in Portugal, social workers are the ones doing the link worker role because they don't have the funding or the resources that England has contributed to this. But I think there's a huge drive behind this in England, and that's why it became policy at the end. It was because people realized and noticed the unmet social needs and mental health needs. And we were solely focusing a lot on the biomedical approach. And so there's been a big push and it's become policy. And Wales is coming up very soon with policy on this and with funding for social prescribing. And we're hoping Scotland is as well as Canada and other countries. It's all looking very positive.
And do we have any final question or questions?
We have from Laura, because of Laura.
Laura, please. Yes.
Yes, hi, thanks very much for your presentations. I just had a question for Jenny that I just noticed that you emphasized a couple times that the community connectors are not volunteers. What did you mean by that? I'm guessing they aren't paid, whereas the health connectors are paid members of the medical staff.
I think there's a huge amount of fear when I do this, when I talk to people about community connectors. They say, well, you can't have a homeless person supporting somebody else. And we say, well, why not? And they say, well, you can't have a 17-year-old telling someone where to get support in the community. And we say, well, why not? And they say, because they're not formal volunteers. They haven't had their police check. They've, who checks up on what information they're giving? So there's a huge amount of fear around this. And people say they've got to be formal. So maybe it's different in Sweden, but we have this distinction between sort of formal volunteers who are people who have to have a police check. They have to have a sort of informal interview and a role description. Whereas these community connectors are just, it's like your son or daughter, when they're 17. Is it a son or a daughter?
Son.
Your son, when he's 17, he might say, I really want to know where there is support in the community. And he finds out about that support for himself. And he thinks, God, one day I would like to be able to tell my friends, if anyone asks me, I want to tell them where they can find out support. That's all it is. So it's just telling people where those access points are. So that's why we say it's not about being a volunteer, because I think people have to let go of the fear and give, because so all that information has been professionalized. You have to go to a professional to find out this information. No, you don't. communities always used to give each other that information, all used to trust each other. So it's about building that trust back into communities, that we can support each other rather than going to a doctor to find out that information.
Yeah, and being a good neighbor, basically, is just being a good neighbor for the people around you. And I think we formalize that too much, and I think it's slowly changing, and that culture is really important to change, and it starts very early. But it's interesting, again, you know, what Jenny was saying, it's so important to have people leading other people and leading change in a non-informal way, as we used to do for years in tribes and in communities around the world.
Thank you so much for question and answers. We have time for one more question. It's Bain.
That's me from Simrishamn in Skåne. And we have talked to Jenny before. And I just want to say that we admire your model so very much. And we really are trying to be mini-from with talking benches, talking cafes, and health connectors and so on. We are on our way with a project. Thank you so much. And very nice to listen to you, Dr. Bowden, too.
Lovely seeing you again.
You will.
Thank you so much. So that's Bertil Jönsson from Simrishamn.
Yeah.
Yeah, we got connected through Jenny. So this is amazing. You connect Swedes also. And one more question, Ulf Måwe, please. What? Can you unmute?
I can unmute, and I also try to speak English. I'm so glad to see that an invention from the English National Health System, which I visited for several times. And I've been to Bromley by Bow Center for 2 times. We visited in 2019, and we had Sam Everington from there as a visitor for our Swedish leaders of the healthcare system in 2019. And one of our members was Bengt Lönnegård på Husläkarna I Umeå. And he was so glad to hear what you have fixed in the national health system. And from the GP perspective, it's very, very important what you say today. We are so glad to, because as I am engaged in educating Swedish GPs together with Meta Wiborg, as you can see here, we will thank you so much to do this input, because seeing Bromley by Bow Center in East Poor London, what they have achieved after 35 years, I'm so impressed. And now you are doing something which will take place in all over the world. I was on a meeting last week with 22 possible members of a SP, Social Prescribing Network. And we intend to visit, now start with, see what the Netherlands has done. We know that they have worked with this for 10 years. So we are a little after here in Sweden, but we will come forward. And the starting point in Sweden is Husläkarna I Umeå, where it's beginning. And this meeting, I think, is one of the first. So you are very important for us, I think. So once again, thank you, Bogdan and Jenny, for your day, for your today.
Thank you so much, Ulf, and we'll see you in the Global Alliance talks, I'm sure.
Thank you. Thank you, everyone.
Thank you. And you know, all the good things come to an end, but we'll be in touch. we have Jen's contact details. There will be some information gathered towards the end of this meeting that we will share with you, and there will be a continuation, like the snowball has started to roll, and we're onto something great here. But now Anna wants the word, so we say thank you so much.
Bye everyone. Bye.
Tack ska ni ha.
Bye everyone.